priapism, it's not just a prolonged erection for more than 4 hours. So it persists, the erection persists even after orgasm. So, and without any sexual stimulus. So even after orgasm and without any sexual stimulus, it persists. That is known as priapism. Okay. So that's a complete definition. Now, so first is you mentioned about the clinical examination and the history. Second is the Doppler ultrasound, and the third is a blood gas analysis. So this is very important. In the examination, as I said, you will get a painful rigid erection. In a Doppler, you will say sluggish flow or decreased arterial flow. And blood gas, you will get this picture that is a dark colored blood, and that will gradually, these are dark colored bloods, and gradually this will become fresh. So to define an ischemic priapism, these are the criteria. The oxygen will be very less and the pH will be very less. So there will be acidic pH and there will be oxygen will be less. So in a high flow priapism, it will be just opposite. So just remember, you guessed all the, you got all these things right. So I'm not discussing them into details. Again, the same things. So whenever you get a patient of priapism, again the same thing. This is taken from this chart only. First, we do a clinical assessment. Clinical assessment includes history and an examination. Number one. Number two is we go for a blood investigations. That is a full blood count, hemoglobin electrophoresis. Third is we get a ultrasound Doppler. Okay, ultrasound to look for the blood flow, whether it's a normal arterial flow or a sluggish or decreased arterial flow. And number four is a blood gas. You put it in needle and you aspirate the blood and you send it for. So this can be both diagnostic and therapeutic. That's all written over here. So the pathophysiology of an ischemic priapism, it's like a compartment syndrome. Okay. So what happens is first there is decrease in the outflow. The problem is not, initial problem is not the ischemia. Okay, the initial problem is a decrease in the venous outflow. So if these are the emissary veins which are responsible for the drainage of the venous blood from the corporal bodies, and these emissary veins are within the they're compressed by the tunica. Okay, so if the emissary veins are compressed, the venous return is decreased, and that is how erection is maintained. But if this emissary vein continue to remain compressed after the for a prolonged time, then there's pressure is going to increase, and the increased intracavernous pressure is going to prevent further fresh arterial blood to come. Okay, and so then there will be a decrease in the arterial flow, and that is how the term ischemic priapism. So the main pathology is a venous occlusion which remains persisted for a long time. So initial management, you need to know the success rate. You mentioned it correctly, 24 to 34%. It's okay if you remember it 30%. And so you put injection, you put needles into the corpora, or you can put it, so you can put it from the corpora 3 and 9 o'clock, or you can put it from the glans. So anywhere you can inject the butterfly needle, 18 gauge needle, and you aspirate it with a bright fresh blood. Okay, so 30% patients may just uh, cure by this. If not, go for irrigation with saline. And the next is you go for an intracavernous phenylephrine injection of 200 microgram. You inject it every 3 to 5 minutes, and till a maximum dose of 1 milligram. Okay, with you don't wait for more than 1 hour. You see the response. If you're not getting response in 1 hour, move to the next line of management. Now, this is something important. Why not? Patient has come to you with a priapism. Why you, if the success rate of just aspiration is 30%, and you know the intracavernous phenylephrine is more effective, why not just put a phenylephrine? Why you have to empty, aspirate it, and then put a see if it is not working, then you give this. One reason is because of the side effects of phenylephrine. It is very cardiotoxic, so it is going to cause your hypertension, and there can be palpitations. So you need to monitor the cardiovascular vitals. And apart from that, if it has been seen that if you first do an aspiration and then put an intracavernosal injection, in that case, the success rate is 80%. However, if you just straightforward go for a phenylephrine, the success rate drops to 60%. So this is important. If you don't get success with the phenylephrine till 1 hour, your next option is a surgical shunting. Okay. Now, when do you go for? Now, this is something primary penile implantation. Okay. The word primary, you need to understand what is happening. Now, primary penile implantation is, suppose the patient has come to you at 48 hours. In that case, you have not done an injection, you have not dilated, you have not done a tunneling, you have not put any phenylephrine. You straightforward go for a MRI, biopsy of a smooth muscle and a penile prosthesis implantation. Okay, that is a primary treatment. But if you have done all this and the patient is not responding to it, and then you offer the patient, that is not a primary. Okay, just slight. I'll come to this again. Now, what is about this phenylephrine? You need to remember it comes as a 10 milligram per ml. Okay, so there is already 1 ml. So in this 1 ml, you are going to add 19 ml. So it becomes 20 ml. This 20 ml bottle is not going to contain 10 milligram of phenylephrine. Now, so 1 ml is going to contain uh, 0.5 milligram, which is 0.5 milligram, which is equivalent to 500 microgram of phenylephrine. So if you just take 0.5 ml, it is going to be 250 microgram of phenylephrine. Okay. So you need to inject it every 3 to 5 minutes. Sorry. So you need to inject it every 3 to 5 minutes. After injection, make sure you massage it, the corpora, to distribute the drug, and monitor the blood pressure and pulse every 15 minutes for 1 hour of the injection. The examiner is going to ask you every details of this to see how safe you are while administering a phenylephrine. Make sure you say on your own. Don't let the examiner ask you how do you monitor and